sharing. Yeah, so I'm gonna talk in English today. I thought I had to, but I can talk in French. During the question period, I can answer English and French questions. So choosing wisely, from knowing about it to implementing it. That's what we're going to talk about. And you already know that I'm the co-lead for Choosing Wisely Canada. So as of potential conflicts of interest, many were already mentioned. So I have some potential financial conflict of interest as in my role with Choosing Wisely Canada, as a facilitator for practicing wisely and when I give different conferences. But intellectually, I also have other potential conflict of interest. You already know I'm the co-chair of the Canadian Task Force, which I do receive expense reimbursement, but it's a voluntary mandate, and I'm on the board of Choosing Wisely Quebec in the scientific committee of TOP-MF. So my objectives today, the objectives for you, hopefully, is that you will be able after that to start quality improvement project based on Choosing Wisely recommendations, or maybe you will even possibly undertake research that address low value care. So Choosing Wisely Canada, what is Choosing Wisely Canada? First of all, we are reaching our 10th year of existence this year, and it's a campaign to ensure that physicians and primary care providers can reflect on things that we might wish to do less or are not doing in our practices. So it is the national voice for reducing unnecessary tests and treatment in Canada. You probably have seen this report before. This is a report that was published in 2017 by the Canadian Institute for Health Information, where it was estimated that 30% of what we do, tests and treatments, are potentially unnecessary. This was interesting as a measure because we know of other measures in other countries around the world that varies between 20 and 40%. So we think this is probably something that does reflect what's happening in Canada at this time, in 2017. We had a follow-up report in 2022 because Choosing Wisely wanted to see, are we making any progress? Is things better? Are things better? So we saw that there were, out of 12 things that we looked in 2022, there were 8 that were improving. So there was less overuse for 8 of them, but it was still marginal improvement, so 10% or more of improvement, but it was not like a very huge chunk of decrease in those unnecessary tests or treatments. So we are thinking that we need to do more. We need to do more implementations, and that's what I'm gonna talk to you about today. So just to make sure that we understand each other, because I go back and forth between terminology. So high value care, it's care that has, health outcomes that matters to patient at the center of what we do. These things are informed by scientific evidence and tailored to patient values. And low value care, what's kind of the opposite. It's where we provide medical interventions that have little or no benefit to patients. Resource stewardship is what allows us to go from low value care to high value care. So it involves making decisions to achieve the best possible outcome. And that's what we at Choosing Wisely want to bring forward, is how do we make that happen? How do we shift from low value care to high value care? So you probably all know about the Choosing Wisely recommendations. I put the family medicine one here. There's more than 300 recommendations on our website. These recommendations are some things that you should not do or things you should do less. And they're updated, like the family medicine one will be updated soon. There are new ones coming in also from new partners that will, make their own recommendations. So there's a wealth of ideas in these recommendations. But Choosing Wisely Canada, because Choosing Wisely is worldwide, it is in more than 20 countries, but in Canada, we didn't want to stop at just making recommendations. These are known by many, but are they put into practice? And we want really to look at how we can implement those things. So what we do, well, there's a clinician engagement part. That's one thing. To try to build a culture of reducing low value care. Actually, what's funny is that recently Choosing Wisely Canada hired a survey group to look at how, we were known across the country, and they were very hard pressed to find primary care provider that didn't know about Choosing Wisely. But that doesn't mean that they are implementing, the recommendations. So what's very important, I think, for today is the implementation. How do we adopt these evidence-informed practices to minimize overuse or low-value care? And how do we measure the impact? So Choosing Wisely has done a lot of work to try to measure impact. But as for now, the most of the work that was done in hospital settings. You probably know of the big, campaign like using blood wisely, or using labs wisely, or choosing wisely hospital designation. So these are big campaigns that were aimed at measuring the impact of activities to reduce low value care. But this was in hospital settings. And we are still doing those things. They are there. If you are in a hospital and you want to get the designation, this is a good time at the moment to try to get the designation, because there's a momentum in Quebec to support hospital to acquire this designation. But this is part of the thing, and this is a little graph that is shown by one of my friends many times in when he presents Dr. Grad. And I think this shows here that the hospital, this is all the ecology of healthcare. And when you're in the hospital, this is not, where the big practices are happening. If we could tackle the primary care providers and what is done at the primary care level, we would have a much bigger impact. And that's what I'm going to try to present to you today. What is our thinking? And I'm going to give you a lot of ideas of how and what you could try to tackle in primary care practices. So implementation is where the rubber hits the road. Yeah, that's always there, but we are aiming to change that. We did try an implementation project in family medicine a few years back, and it was quite difficult. And we realized that we cannot do a fits all like we did for hospital, like with the blood and the labs. We have to tailor what we're doing, and I'm going to show you some of the ideas that we had. So in the implementation spectrum, I'm going to talk to you about quality improvement projects that could be done by audit and feedback or in other manners, and some ideas of research also that can be done to increase practices that will foster high value care. So this is the primary care strategy. It's an overview. It's something we are working on at the moment. So it's not finalized, but I think it's thought about enough that I could present it today. So you could see, of course, we still want, people to be aware and people to align with the message that we are giving. But we really want to look at how we can measure change in the family medicine settings, primary care settings. This is all to be developed, but there are a lot of tools already existing that I'm going to show you. And one of the things we are thinking about is to have some form of recognition for family medicine teams. This is something that last year I spoke about in a conference, and everybody was very enthusiastic about having this kind of recognition. At the national level, it's still very early in our thinking, but at the provincial level, with Choosing Wisely Quebec, it is something we would like to achieve in the next maybe year and a half, to recognize family medicine teams that do embed Choosing Wisely recommendations into their practices. So implementation at scale. So how can we catalyze the adoption of these practices, high-value care practices? So most people know about the recommendations. Not so many people know about the toolkits. So I'm going to show you some of the toolkits and explain what they are and how you can use them. So there are many toolkits available, and you can see some of them are more like hospital-centric, like drop the pre-op, or why give one when one will do about blood transfusion or urinary catheter. But there are some in there that are applicable to a family primary care setting. For example, there's the drowsy without feeling lousy. This is about benzodiazepine. The TSH, which is about not prescribing these blood tests when people are asymptomatic, like as a screening tool, for example. The antipsychotic, how to reduce the prescriptions of antipsychotic, and the PPI one. It's also aimed at reducing or reconsidering the prescriptions of PPI. And these toolkits they're living. I mean, they are new toolkits, maybe not all the time, but we have a very new one that was published in February 2024. This as a look at rural medicine. So it's to reduce unnecessary patient movement for medical care. And I'll show you what is a toolkit, because this is something that you could do in your clinic, in your setting. So a toolkit is generated by the user. It is a group of people that have done something to look at a practice, and they author a toolkit like this. It is peer-reviewed, so there are people that are going to look at the toolkit, and it is, though short, simple, practical. It is a description of what you did and how you did it, so that it could help other practices do the same thing. And it is a living document. So if you do use one of the toolkit in your practice and you say, well, maybe that could be said a bit differently, or we tried that and that worked a bit, that was more easy to implement that way. This is something that we could help you do, update any toolkit. And if you're interested with that, do contact us at Choosing Wisely Quebec. We will make everything to help you do that. So what you find in these toolkits, you find all the components of an intervention. So a QI project, for example. So how to set the table, what are the things, all the steps you could do, and what to measure, including the balancing measures. So making sure that, doing less is not causing another problem. And then all the resources and the tools to support that change. So this is one example of a family healthcare team that did use the Bye-Bye PPI toolkit, and they reported that they were able to decrease the use of PPI by 26%, and they had at least had a conversation with their patients in 93% of the case, and reported as a balancing measure that they didn't find any negative impact. So you can, make your own toolkit. If there is a recommendation out there that you feel it's very important to you and you want to implement that, then you can write your own toolkit. We will help you do that. We have a template. It's kind of, not so hard to do, and we will provide all the necessary help that you need. I'm going to show you an example at the end of something that we did in my family health teams. I won't report that much of the data because they're not so good, but I'll tell you about it. So this is, going from here, which was, a family health team, taking a toolkit and putting it into practice, into looking at something of more of a research across family health teams. So this is a report about, trying to implement the toolkit, the tools, the resources, the steps into 5 different family health teams. That was done in Ontario, and you could see the percentage of patients that either stopped or reduced their PPI use. So across the 5 family health teams, 60% of those were able to reduce PPI. So from a toolkit to something you do in your own clinic, to something you could do across a small region, for example. And if you want to go even wider, this is a very recent article from January 2024, published in JAMA Internal Medicine, where it's actually a cluster randomized clinical trial. And what they did is they took 8 primary care clinics, and they had many primary care clinicians that did participate, I think above 80 primary care practitioners. And what they did is they used strategies of behavioral economics, which I cannot really describe, the science behind that, but they had these practitioners, commit. They had to write that they would commit. It was put in the waiting room that these physicians had committed to ensure that they would avoid use of hypoglycemic medication to achieve a tight glycemic control that was in an elderly population, and to avoid sedative and hypnotics medication for insomnia or anxiety, again, in an elderly population. So, you could do the little thing in your clinic, you could do it across clinic, you can even think of doing, formal kind of research like this one, which is a cluster randomized one. So I hope you are having some ideas, as of now. So quality improvement, to me, it's a kind of research or formal research. You could use the toolkit. Please, if you do, document what you did. We are quite interested to know how it went and how we can help the toolkit to be better. Share it. I already said that. And why not? Why not there and write your own toolkit? We will share it, across the province. You could also think of evaluating your own toolkit or any toolkit, and make research into practices that are linked into what the toolkits do provide. So these was the toolkits. Now I just want to show you other kinds of tools that exist that are not necessarily done by Choosing Wisely, but Choosing Wisely did participate in some of those tools, because we recognize that we say less is more, but green is better also. And there are a lot of interactions. Actually, if you want to have an impact on carbon dioxide emission, just prescribing wisely is one of the most important way a physician can have an impact on CO2 emissions. If you look at that, this is from Australia, and they did look at, the carbon footprint of clinical care, and you could see here they estimate at 40%, either low value care or even harmful care. And this is a big chunk of, what are the carbon emissions. So clinical care is very important in the footprint that we have, and just changing some of the practices, some of the low value practices can have an impact on carbon emission. And we often don't think about that in that way. So this is from BC, and this is Planetary Health for Primary Care. I don't know if you saw this, but these are also, this is a toolkit if you want. It's a bit more big. There are many, many ideas in there. It goes from, making sure you use the paper on your table wisely to prescribing some of the medications that do have impact on the environment. One thing that links this toolkit with choosing wisely is the campaign that we had about Let's Clear the Air. This is a campaign to encourage clinicians and patients to make sure that we do have a diagnostic, first of all, about asthma and COPD. So because what we realized, there's, so many people that do take puffers. I don't know why it's doing that. I'm sorry. It's doing that by itself. That do have puffers, and that don't have a diagnostic. They don't even have the diagnostic of asthma or COPD. So you could see here out of 100, there's 33 individuals that don't have, I have no idea what's doing that. I'm sorry. 33 that don't have actually when they're tested asthma or COPD, and 26 of them were on medication. And we know that these medication, the puffers, do have an impact. And this is tools that we have to help this discussion. There's many other tools you can find. BC, the toolkit does provide many tools. Because we know that, a puffer has a big impact. And if you switch to a powder inhaler, it does have an impact. So first of all, make sure the patient has a diagnostic. And second of all, try to prescribe an inhaler in powder. And that's interesting. And I opted to show you that because it's another idea that you could have. And I know of a healthcare team in Montreal that is actually doing that, trying to investigate the practices in their clinic and maybe change the way practitioners are approaching asthma and COPD and their prescriptions of medication for these health problems. And a very quick thing you could do also is make sure you use gloves appropriately. So that's another campaign that Choosing Wisely Quebec is supporting. So you will probably see those kinds of posters around eventually in a few months. So we looked at the toolkit. We looked at the intersections of, less is more and greener is better, and other kinds of toolkits that are there that could give you a lot of ideas of what we can research into just doing quality improvement, or what you can research to make sure and ensure that low value care is tackled and we are aiming for high value care. So there are other resources, other campaigns that are aimed at family practice that you probably know about. The Using Antibiotic Wisely campaign. It's an effort to encourage the conversation between clinician and patients about unnecessary antibiotic use. At first, this poster that you see here did ask for a commitment by physicians. So physicians were signing the posters and putting that into their waiting rooms. At this moment, there's no place, but you could sign it if you want. But it was thought of this way at the beginning, a bit like I showed you in the cluster randomized one. So there are a lot of information also in the toolkit that you could use. We have good practices when not to give antibiotics for bronchitis, otitis, sinusitis. And there's also in the cold standards one page about the duration of antibiotics. So if you do have to give antibiotics, maybe you will realize that sometimes we give too long of an antibiotic. So these are all things that could be researched in your clinic that could be looked at. Are we doing the right thing? Are we prescribing too much antibiotics? Are we prescribing too long duration of antibiotics? And I'll circle back to this at the end to show you that we are putting together some tools to help you do this. And this is new tool that you might not know about. It's quite new. It just was published or put, sorry about that. It's the bronchiolitis less is best tool. So that was in the fall, and it was released in the fall. So it's a way for you to also look at practices. You see here, do and don't do things when it's mild, moderate, or severe bronchiolitis. So it was devised by family doctors and pediatricians, and is really to help the practice of doing less in bronchiolitis. Of course, if we need to do things, it's one thing, but there's many ways we can improve our management of bronchiolitis. So this is another ideas or many other ideas of things you could look at in your practices. Oh, it's just getting bigger. And for that, so for the first tool that I showed you, and for this tool, we have these non-pharmacological prescription. So there is the viral prescription. I hope you know about the adult viral prescription, and this one you see here is the pediatric viral prescriptions. So the adult one now looks like this one, and it's really to ensure that, we do help patients in these situations, because often physicians will think, well, the patients only wants antibiotics, when in fact they want to know what they have. They want to know how they can relieve their symptoms and when to come back. So these tools help in doing this. But if you're really interested in research, these tools haven't been researched that much. So it's something that, would give a lot of information to the campaign, and how we can support physicians to do that if you want to research the impact of these viral prescriptions. So like I said, there's the adult one, and there's the pediatric one that can be used with the toolkit that I just showed you. And because we like it, and at Choosing Mobility Quebec, we do like these viral prescriptions, and we do listen to physicians on the ground. So there's another Dr. Theriault actually from the Abitibi that reached out to us and said, I want to do something for insomnia. So what we did videos that will be available soon, videos for your patients that you could look at. So that they will have some information, and it could help, reinforce good practices around this topic. But we have this non-pharmacological prescription for insomnia that you could use also, and this has not been researched. So this is something that if you're very keen on doing this, that would be quite helpful to know how useful these tools are, this tool are. We are coming up soon. We were asked by another group to look at that. And actually in Quebec, I don't know, people like these non-pharmacological prescriptions. So soon we will have available non-pharmacological prescriptions for acute back pain. So if it's something that you want to research topic about, that should be, I think, quite interesting to look at that. And lastly, there's the Time to Talk campaign. This is based on research on how to, I think it's because I already made slides that it's advancing like this. I'm sorry, but this is a tool to encourage conversation between physicians and their patients about when they have serious or progressive illness, about level of care and care that they do wish that they have, their goals and their wishes. And it provides, a toolkit or, conversation guides and these conversation guides are based on research and they are helpful. So what we did in our clinic, I told you I would talk to you about that at the end. We did look at the level of cares and the decision about the wishes of our patients, our elderly patients. And now we were documenting it. Truthfully, I didn't think it would be so bad, but it was quite bad. We didn't have a lot of documentation, so it was all over in different places in our electronic medical record. So we did that. We took all our patients that were 75 plus. We randomly picked patients from this pool by different doctors. We had a quick survey. We looked if we could find easily if the level of care was discussed. We realized it wasn't the case. So we had these tools, some videos to look at. We made a meeting and we decided how we're going to approach that from now on. And we had a structured plan with, the secretarial team, how we're going to place all these things in the electronic medical record. And 6 months down the line, we did look at it again. It was better, but we still are in the process of doing like our PDSA cycle and trying to improve this. And why I'm telling you this is because at the college, we have these tools to help these quality improvement projects. So what we did in our clinic was kind of the pilot, and this way of doing it as a group, looking at a specific recommendation or toolkit, we will implement into our new website that is coming on in a few weeks, maybe no more than 2 months, I think. We will implement those tools, and it will be quite easy for you to follow the process if you're interested, and we'll gather some of the information from these exercises, and it could give you readily in the platform the credits that you need, the credit B, I think they're called by the college. So now at the moment we do have those. They are not that nice looking, but they are available, and it's mainly about the antibiotics and the upper respiratory tract infection, but we will make many more, and we will make some of them will be not just personal but by teams. So I'm almost at the end. So I always say that the 3 words that cost more in healthcare is just in case. So just make sure that, we practice a more high value care medicine. This is the goal. This is why Choosing Wisely exists. It is to make sure that the patients do receive the care they need, but do not receive care that they don't need, because it comes with some harms. If you want to do a research projects or QI projects or something, an idea that you have, be aware that in every university there are STARS students and trainees advocating for research stewardship. So every year in McGill we have 2 STARS, and they are very keen into participating into any idea that you may have. So I think, we really need to think differently. And I think that research, family medicine research into how we can reduce low value care is urgently needed. And I hope that today you had a lot of ideas on how you could, do something different in your practices, or even do some research into low value care. So now it's time for you to decide what are you gonna tackle today or tomorrow or in the months to come. That's it. I think we have some minutes for discussion. Nicholas?
Thank you, Dr. Theriault. I just wanted to say, first of all, on behalf of the Department of Family Medicine, we would like to extend our sincerest gratitude for your presentation and invaluable insights and your expertise today with us. Your knowledge and recommendations will certainly help us guide improving healthcare practices. And now we'll leave it to the attendees in the room. So I'd like to invite all audiences to either raise their hands for their questions to be addressed, or it can also be placed in the chat for any queries that you might have. I do see one question from Mark first, so I think we'll address that one to begin with.
Thanks very much. And Dr. Theriault, thank you for your challenging presentation. As a clinician researcher, I'm comforted by the fact that I'm achieving most of the goals that you have defined for us. Having said that, in one of your earliest slides, you gave us a definition of low-value care, which I think stated is no value to patients. And I would ask where those words came from, because there are two interpretations of the words no value to patients. No value to patients judged by whom? By the clinicians? But that's what we're getting to. By the patients, that's a different issue. And probably the biggest challenge that we have in practicing wisely is convincing patients that it is of no value. And I'm saying that because this week in particular has been an awful week for me in my practice, having to engage to this kind of discussion with more patients than I'm accustomed to. So I'm interested that people are comfortable giving us this definition of no value to patients. The patients would say it's going to alleviate my anxiety, therefore it's of value. Well, while we disagree with that, we still have to recognize that we're supposed to be working as a team and sensitive to patient needs. Any comments?
Yeah, thanks for this question. It's very interesting. So I noted some points. So first of all, about the anxiety. So that's interesting because effectively, if patients will think that doing a test or something will relieve their anxiety. Actually, research do show that it does, but for a very short amount of time. So if you want to relieve the anxiety, I think it's more like listening and explaining to patients what is wrong and offering a follow-up, much more than doing a test for no reason if it's not of value, medical value. But the other thing that you said is trying to convince patients. And this is something that we really want to change the way we look at that. We're not trying to convince patients. We're trying to, like you said, be a team with the patient. So, listening to why they would like this test, giving them information, aligning with them, saying, yes, I understand. This is a stressful situation. These are all tools that can help this conversation instead of trying just to convince patients. Now, what about the low value care? I think you're totally right. So there's some low value care that is totally not medically necessary. For example, there's an antibiotic in bronchitis, that just began 2 days ago, you started to cough. So this is something that is totally of low value. But there's a lot in between where shared decision-making is important, like you said. So we will, when there are two options that can have some values, and there are equipoise, then shared decision-making is quite important. But at times, there are things that, shared decision-making is not of value. I mean, I will not begin a shared decision-making process with a patient where I do not feel antibiotics can be helpful at all. But I will have a shared decision-making for example, many screenings or some treatments that I feel like may be, of interest to the patient, or I'm not sure it's going to help them. Yes, I'm going to say, well, this way or this way. And there's the high value care. The high value, really high value, is when there's no doubt. If you're in an accident and you bleed from everywhere, I mean, there's something we need to do for you. It's not something I'm gonna, it's not an in-between. So I think there are the two extremes. There are a lot of in-between, like you just said. But I think in the in-between, that's where shared decision-making is. But in the low value, where it's really not relevant, then it's a different approach, not of convincing, but of, we have three words. We say, what is it? Acknowledge, align and then give some information. So you do acknowledge that you acknowledge their fear or their concern, you align with them, and then you try to give them information. And I have many instances in my practice when I did that, and I was surprised, of the reactions of patients. But trying to convince is not something, it's not something that works usually. I hope that answers the question.
Thank you.
Dr. De Pocamundi, the floor is yours.
Thanks. I'll just mention first, there was a comment by Mark Ware that said the great work. Please share the links to low back pain non-pharmacological prescription when available. So he's going to be interested when that comes out. I want to ask you kind of a different side. The infrastructure of choosing wisely. You mentioned there's a Canada, but it's also international. Can you expand a bit more on where it started, where it's at, and what's the future? Is it going to be funded for a long time? Because, there are many campaigns, but what's the durability, the longitude picture of choosing wisely?
So it started in the United States. That's where it's all started around 2013. And then Wendy Levinson was actually part of this startup in the United States, and she's Canadian. So she brought the idea to Canada, and the campaign started in 2014 here in Canada. And it started like I tried to say at the beginning, it started as a campaign, just, making people aware there were low value care practices and, things that they could do less or they could do better or they could stop doing. So it started like this, but soon we realized we needed to do more. We needed not only to make people aware, but to have some tools to help people implement this. And this is where Choosing Wisely Canada differed or was different from the US. Because the US was still just, basing most of their things on the recommendation. But the Canada, we did do things that were different, like toolkits, the STARS program, which is the students, and trainees for advocate and research stewardship. So this is things, all ideas that came from the team at Choosing Wisely Canada. Some of these ideas have been taken into other countries. I know STARS, I couldn't tell you in which country, but I know this was taken by other Choosing Wisely countries. So there's about 25 countries that have Choosing Wisely initiatives. Some countries don't have much. I was in France yesterday and they barely know what Choosing Wisely is, but some countries are more active and they sometimes have different names. Like in Italy, they call that slow medicine, something like that, because there's adepts of slow food and things like that. So they make it relevant to their own settings. There are meetings from those countries once, I think it's once a year, maybe with the COVID, it was once every 2 years. They meet together and they try to strategize. As for funding, we are assured funding by Health Canada for many years to come. So I don't know the specifics, but we are not dying. We're there to stay. So, and we are assured funding because we are not doing the same thing over and over again. We want to try to find new ways of addressing the problem of overuse in healthcare. I hope that answers your question.
Yes, thank you. That's great. I don't know if anybody else would have a question. There's one.
There, Valerie, you can unmute.
Thank you.
On peut parler en français, Valérie. Tu peux parler en français.
Oh, mais
Ouais.
merci. Je ne savais pas que tu parlais si bien anglais, Guylène. Je me demandais, est-ce qu'il y a des études pour voir la satisfaction des patients? Tu sais, je comprends qu'on rentre dans un partenariat avec le patient et non dans une confrontation d'essayer de convaincre puis de dominer l'idée du patient. On essaie de vraiment le rejoindre à moitié chemin puis travailler avec lui. Mais est-ce qu'on sait que le patient va adhérer au projet? Est-ce qu'il y a des études qui nous disent ou est-ce que le patient va sortir du bureau et dire très bien, lui, il ne veut pas me donner des antibiotiques, je vais m'en aller aux urgences, puis là, je vais en recevoir?
OK, bien, avec l'exemple des antibiotiques, ça, je peux vraiment te donner des données là-dessus. Donc, il y a eu une revue Cochrane où ils ont regardé, c'est surtout sur les otites, OK, mais ils ont regardé la prescription immédiate d'antibiotiques versus la prescription différée d'antibiotiques versus ne pas donner d'antibiotiques, OK? Et ils ont vu que effectivement, quand la prescription était immédiate, il y avait beaucoup plus de monde qui la faisait remplir, la différer moins, puis bien sûr, s'il n'y en avait pas, encore moins. Sauf qu'ils ont gardé la satisfaction des patients et avec toutes les stratégies, la satisfaction était la même. OK? Donc, la satisfaction ne vient pas de la remise de la prescription, mais bien de la discussion autour de tout ça. Puis moi, je vais te dire, je varie un peu mes stratégies. Tu sais, si c'est vendredi soir, je vais peut-être donner une prescription différée que j'aurais peut-être pas donnée lundi matin en disant, ben, revenez mercredi si jamais ça va pas. Fait que, tu sais, on peut varier là-dedans, mais je vais essayer de ne pas donner une prescription que je crois qui n'est pas justifiée, par exemple. OK? Fait que je pense que les patients, ce qu'on voit dans la littérature, en tout cas pour les antibiotiques, c'est le fait qu'on se dit, ah, les patients viennent parce qu'ils veulent des antibiotiques, c'est notre perception. Les patients, ce qu'ils veulent, ce qu'on voit dans la littérature, ils veulent savoir qu'est-ce qu'ils ont, qu'est-ce qu'ils peuvent faire, puis quand est-ce revenir si ça ne va pas. Quand on a ce continuum-là, puis qu'on sais, moi, combien de fois j'ai dit à des patients, écoutez, si ça ne va pas, là, revenez, je suis là vendredi matin, puis si c'est plein, je vais vous prendre pareil. J'ai fait ça pendant des années. Ça m'est arrivé une fois qu'il y a un patient qui est revenu. J'étais même toute surprise. J'étais comme, OK, bon, ça marche, cette affaire-là. Là, tu sais. Fait que c'est vraiment ça. Fait que, mais la satisfaction des patients, par exemple, de la prescription virale ou là, de la prescription non pharmacologique pour insomnie, ça, c'est un beau sujet de recherche. Ça, c'est vraiment un beau sujet de recherche parce que ça, c'est un peu nouveau. Puis même s'il y a eu un petit peu de recherche, il n'y en a pas eu beaucoup. Puis on pourrait certainement en apprendre beaucoup d'une recherche sur ce sujet-là.
Is there anyone else who might have a question? If not, I do have one of my own.
Yeah, sure.
Okay, so one question I do have centers around the transitory process from low value to high value care. And I'm wondering, what opportunities do you believe exist for leveraging digital health technologies, for example, to facilitate the appropriate application of some of the choosing wisely principles that you've recommended for clinical practice?
Mm-hmm. Yeah, so we have to, so prompts could be something that you could put in your digital, but you have to be careful with that because too many prompts and nobody is looking there. It's a tired, physicians become tired of these prompts. So if you choose a prompt, might be for a short period, to really help physicians think about something. But there are other things you could do, for example, and it's not quite specifically related to choosing wisely recommendations, some of them, but like for screening purposes. So what we did in our clinic is that if I see a man of a certain age, I put man, and then I have all the things that I should do and only the things that I should do for him. So I will not be, thinking of doing things that are not appropriate for this age group or this gender. So that's something that you could embed easily it's not a prompt. It's something that I have to go and fetch, but at least it tells me what I need and what are the good decision aids that I can use to help my practice in that way. So, I think digital can help. You could have pharmacology-wise, you could have some prompts to say, do you really need to prescribe this antibiotic for that long, for example? Maybe you only need 5 days. Are you sure you want 10 days? But you have to be wary that these prompts, sometimes people, get tired of them. So use them wisely, I think, would be what I would say. Or for a short while, you could use them for a short while until, because even me, I'm an older doctor. And, you know, it took me a while to write 5 days on a prescription, you know, and not 7 or 10 days, because I was trained to give 7 or 10 days. But, you know, with time, you know, you're able to change your practice. Does that answer your question, Nicholas?
Yes, very well, thank you. I am still monitoring the chat. We have about enough time for 2 more questions.
Alors, je vais y aller, moi, d'une autre. Je vais être particulièrement intéressée avec les trucs sur l'infection respiratoire et faire des suivis là-dessus parce qu'on a un projet avec l'unité SSA sur les infections respiratoires. C'est beaucoup, présentement, on est beaucoup à travailler avec les patients partenaires pour voir ce qu'ils veulent avoir comme information, mais il y a beaucoup d'outils on va voir si on peut faire une suite avec vous. L'autre chose, par exemple, je voulais voir, c'est quoi le défi principal de Choosing Wisely? Parce que justement, c'est des beaux produits, mais comment le faire connaître dans les défis dans l'adoption dans les cliniques? Parce que je pense que c'était toujours ça le problème. C'est vraiment génial quand on voit des outils, mais il y a tellement de ressources comme médecin de famille que ça devient à un moment donné très... c'est comme trop comme passé, là. C'est des toolkits, il y en a vraiment beaucoup. Fait comment vous vous y prenez pour comme publiciser puis pousser l'implémentation?
Oui, il faut comprendre que Choisir avec soin Québec, c'est quand même assez jeune, hein. On a probablement 2 ans, j'imagine, là. Fait qu'on a quand même réussi à faire certaines choses depuis ces 2 ans-là. On a beaucoup fait d'advocacy là, avec tu sais, le ministre, l'INES. Tu sais, on parle à beaucoup de gens autour pour faire connaître Choisir avec soin. Mais je pense qu'il y a encore du travail à faire pour aller sur le terrain, dans les milieux, dans les GMF et tout ça, pour faire connaître nos outils. Une des idées qu'on a eues, et ça va vraiment être plus mis en place dans les prochains mois, c'est d'avoir cet outil-là au moins pour gagner ces crédits là, de niveau B qui nous fait mettre en place une recommandation. Puis ce qu'on a développé, j'ai essayé de le dire à la fin, c'est que oui, on peut le faire de façon individuelle, mais bientôt, on va ouvrir à le faire de façon en groupe. OK? L'autre chose qu'on est en train de réfléchir, c'est avec l'INES. L'INES a la capacité de donner des portraits à certaines cliniques. Donc là, on commence à réfléchir à ça, mais de voir comment on pourrait utiliser ces portraits-là pour aller dans les cliniques, puis là, dire ben, qu'est-ce qu'on peut faire avec ce portrait-là, puis comment on peut l'améliorer, puis comment on peut se servir d'outils de choisir avec soin pour l'améliorer. Donc, je vous dirais qu'on a des tentacules un peu partout, puis on essaye de trouver une façon. Mais au niveau canadien, c'est quand ils ont essayé de regarder les pratiques en médecine de famille, la diversité est tellement grande que c'est difficile. Fait que, tu sais, les hôpitaux, c'était pas facile, mais c'était comme plus facile, il y avait une certaine uniformité. Mais là, c'était plus difficile. Fait que c'est pour ça que, comment je vous dirais, on travaille très fort en ce moment à essayer de trouver des façons. On va pouvoir rejoindre les médecins dans leur clinique. Nous, on a ces différentes petites façons-là, mais écoutez, si comme chercheur, vous avez des idées, vous voulez faire un projet, essayer une nouvelle façon de rejoindre les cliniciens, nous, on est à Choisir avec Soin Québec, on est très ouvert à ça. Notre idée, d'avoir une espèce de reconnaissance de clinique, c'est quelque chose qu'on va pousser aussi. Puis on espère que ça va encourager les gens à faire des projets d'amélioration de la qualité avec Choisir avec soin en tête là, dans leur milieu. Qu'on n'a pas la recette parfaite encore, mais on travaille très fort. On est plusieurs là, autour de la table à essayer de travailler pour trouver des façons de rejoindre les médecins de famille. C'est un peu pour ça que je suis aujourd'hui ici. Aujourd'hui ici, là, on fait beaucoup d'interventions comme ça publiques. Fait que, à venir, puis peut-être cette collaboration avec l'INES aussi va éveiller certains questionnements là, chez les praticiens de première ligne dans leur clinique. Parce qu'on sait que quand on donne un portrait à quelqu'un, bien, ça l'aide à motiver les gens à se dire, ah, OK, mon Dieu, je vais vous dire que nous, quand on a vu notre portrait pour les niveaux de soins, on s'est dit, aïe, aïe, OK, là, il faut vraiment faire quelque chose. Hein. Fait que ça l'aide aussi.
Génial, merci. Beau projet ambitieux, en tout cas.
Oui, oui, mais c'est ça, mais un petit peu à la fois. Mais déjà, en 2 ans, on a quand même réalisé des choses. Fait que, on espère qu'on va continuer sur cette lancée-là.
Okay, so we have time for one more question, and I see Lawrence, you've raised your hand, so you can certainly go ahead.
Bonjour Guylène. En fait, je t'interpelle comme évidemment directrice de l'enseignement et de la recherche au CIS de l'Outaouais. En fait, ce qu'on avait vu pour les changements de pratique pour les médecins dans d'autres études, c'est beaucoup la comparaison par rapport à une moyenne ou par rapport à une pratique, à une norme. Puis, il y a très longtemps, quand je suis arrivée au Québec, j'avais travaillé justement sur un projet de recherche pour le changement de pratique. Puis, c'était vraiment de comparer. Donc, est-ce que dans certains projets, on pourrait faire une entente avec choisir avec soin sur des choses ciblées, mais on serait vraiment on parle de tel portrait, puis vous avez appliqué, puis qu'est-ce que ça donne après? Parce que ça, souvent, ça fait bouger. Le médecin n'aime pas ne pas répondre aux normes, n'aime pas ne pas suivre les guidelines. C'était vraiment, à l'époque, c'était des projets de recherche avec Joanne Monette. Je ne sais pas s'il y a encore quelque chose, ça date d'il y a longtemps, mais je trouvais que cette association est importante, peut-être.
Écoute, c'est de la musique à mes oreilles parce que un des problématiques les plus grandes pour nous, pour agir, c'est l'accès aux données. D'avoir ces portraits-là. C'est pour ça que là, on essaie de voir avec l'INES qu'est-ce qu'on peut avoir comme portrait. Mais écoute, si on peut avoir des portraits régionalisés, hey, ça serait vraiment fantastique. Moi, Laurence, on se connaît depuis longtemps, mais moi, j'avais essayé d'avoir une espèce de portrait de ce qui arrivait en imagerie lombaire. Hey, c'était vraiment très, très, très difficile à obtenir, même dans mon propre hôpital. Donc, oui, je pense que tout à fait. Il y a quelque chose à faire au niveau de l'accès des données pour donner un portrait au médecin parce que je vais t'avouer que même moi, quand on a fait notre revue, moi, je pensais qu'on n'était pas si pire que ça pour les niveaux de soins, là, tu sais. Puis là, je me suis dit, ben voyons donc, OK, tu sais. Fait que je pense qu'effectivement, d'avoir un portrait, ça l'aide beaucoup à motiver puis à dire, ben comment on approche le problème maintenant. Fait que oui, écoute, on peut s'en reparler, mais si tu peux nous avoir des données, ça va me faire grandement plaisir.
C'est probable que je te rappelle.
C'est parfait, mais moi, je dirais à tout le monde qui est ici, là, si vous avez des idées, vous voulez juste discuter de choisir avec soin, mais de comment vous pouvez utiliser ça, écrivez-nous à Choisir avec soin Québec, facile à trouver quand même notre site web, écrivez-nous, puis ça va nous faire plaisir. Puis vous avez vu, là, la prescription non pharmacologique pour l'insomnie, ça vient d'un projet, de quelqu'un qui nous a appelé, qui a dit, écoute, moi, j'ai un projet, la même chose pour le bas de dos, c'est des physiothérapeutes qui nous ont approchés. On essaie vraiment de répondre là, aux besoins des praticiens de première ligne, en fait. Fait que, oui, j'attends vos appels avec impatience.
Okay, so thanks again, Dr. Theriault. We have arrived at the end of our question period and ending there for seminar today. So I'd just like to express my appreciation again to all of you for your active participation and thoughtful engagement. Before we conclude, I would just like to note that I'm excited to announce our next upcoming seminar, which will be taking place on Friday, April 12th, 2024, featuring Nadia Surreal. We look forward to seeing you all there as we continue to explore important topics in healthcare and medical education. So once again, thank you all for attending. Thank you again, Dr. Theriault, for your insightful presentation, and I hope everyone has a wonderful day. Thank you.
Merci beaucoup, Guylène.
OK, bye, merci.
That was so
Okay.
good.
Thank you.
That was incredible. Thank you so much.
Yes, no worries. And please let me know if anytime you need
I
any
definitely
support.
will. I know Alex was really happy as well. So that's awesome.
Okay, that's
Cool.
great.
Have
Okay.
a great weekend.
You too. Thanks again.
Thank you.
Okay.
Take care.
Bye-bye.